the cutoff on this is 30, and that's the Sheffield cutoff. But in the books, it says less than 15, that equals iron deficiency. If it's over 15, then you need to start thinking about whether this, if you're suspecting iron deficiency, it doesn't necessarily rule it out. So we know that ferritin goes up in inflammation and infection, and the levels can be high in the presence of iron deficiency. So if you have this blood picture here, especially the FBC at the bottom, but say the ferritin was 120/200, if you thought that it was iron deficiency anemia, then you need to be doing further investigation to prove that, essentially. So the next thing you would do is iron studies. And then this is this chap's iron studies. So his serum iron is low. His transferrin, so that's the transporter, is 82, so it's normal to highish. But the important part of this is that his saturation of the transferrins, the amount of those that have iron in it, is only 11, so it's very low. So that's all in keeping with iron deficiency anemia. Now, looking at interpreting of iron studies, this is not something that I expect anyone to remember. If anything, I would Google it and take a screenshot and then take it around with you, because it's something that I learned for my exams and then promptly forgot. But just working through them. So this is our iron deficiency anemia. So you have a low serum iron. You have the transporter tends to be high, but the percentage of that transporter, the transferrin, is low. So that's iron deficiency anemia. Anemia of chronic disease, in particular, I had a look as to why the transferrin is low to try and get an idea, because this isn't iron deficiency anemia, even though the serum iron is low, and apparently there is readily available iron. It's just not there to be used, so it might be in different places, essentially. And that goes the same with the acute phase reaction. When your ferritin is high, your serum iron is still low, that is because the iron stores go into different places that aren't in the serum, so places like the liver. So when you're looking at FBCs and then looking at your iron studies, the main differentiator is actually this transferrin to determine whether it is iron deficiency anemia. And then your iron overload is like your hemochromatosis, where iron's just everywhere. So the next thing to think about is what's the underlying cause of your low ferritin or your low iron, and these are all in keeping with iron deficiency. So I put these sort of in pairs, actually. So malignancy, especially in someone, so in our age range of older people, anyone who presents with iron deficiency anemia automatically goes into a 2-week wait, essentially, for GI malignancy. And that's can be tricky at times, because sometimes you don't want to over investigate these people, and a lot of people have iron deficiency. Alongside that goes with bleeding, and I put chronic in brackets because you don't get this sort of iron deficiency necessarily with acute bleeds, but you definitely don't get the picture of the microcytosis. You might have a normocytic anemia. Even though you might have a low iron, you'll find that it might recover sort of when that period of time where they can reproduce their red cells after it's come back up. And then the other two would be malabsorption and nutrition, and putting those side by side. We see in the older population again that a lot of people don't eat properly, and nutrition is probably actually quite a big cause of iron deficiency anemia, and we very much go down the investigate of bleeds and malignancy. And it's taking that history maybe of, what they eat. Do they have 3 meals a day? Do they have iron in those meals? And then that goes alongside malabsorption. So nutrition is not having the right amount in, malabsorption is not absorbing it. So that could be things like if they've had any prior GI surgeries in the past, or if they things like celiac disease can occur later in life. So it's always worth just doing a screen. I would say sort of bleeding, chronic bleeding in older people. So in younger women, we sort of think about menorrhagia, but in older people, you might be thinking of, there might be a malignancy, but then sort of atrophic gastritis could lead to sort of that drip bleeding. Things like telangiectasia, which are the small blood vessels that are dilated, which could cause a little bit of bleeding. piles. I think that's something that's often sort of not thought about as a cause of iron deficiency anemia, and that sort of regular bleeding that could just cause that chronic anemia. And people who have regular nosebleeds as well, which sometimes the older population do. So I thought I'd throw in a blood film purely because you might see at the bottom of your full blood count target cells and pencil cells, and that is pointing towards iron deficiency anemia. So what are the symptoms of iron deficiency anemia? So the first two we all know about. Shortness of breath and lethargy is something that we see often in people who present with anemia. The other two that are probably less commonly known about are itching and then restless legs as well. And it's probably more the ones that we see in referrals to geriatrics clinic of people who have just ongoing itching that the GP can't sort out, or even restless legs. And the restless legs ones normally come in sort of query Parkinsonism, but actually when you check that iron, it's low, and correcting it can just resolve these symptoms, and that's when it's magic. And that feels like when you've really made a difference. So again, it's just something to keep in the back of your head. If you come across someone in the middle of the night who's got itching and there just isn't a reason why, check that iron level. So we need to think about what we're going to do next in further investigations. So if we think about our 86-year-old gentleman who has a frailty score of 5, has comorbidities, and is currently delirious. So we need to think really what is appropriate for him. So I think in particular, we do need to get a diet history. So we need to find out from his family or from him, if he can tell us what he's eating, to think whether he's got that nutritional deficiency. I think a celiac screen probably is worth it, as long as it's not been done before, to think about whether he has got any malabsorptive problems, and that's a non-invasive thing to do. I think a lot of people end up doing CT chest abdo-pelvises on these patients because it's a fairly non-invasive thing to do, and also it sort of is a screen for malignancy, even though it's not very sensitive really of picking up GI malignancies in particular, but you might see that sort of lymphadenopathy or something, or spread, which is in keeping with malignancy, and then you sort of you've diagnosed it. However, again, if you're not going to do anything about it, there's that risk benefit of whether you should do it in the first place, and it's always something that we should probably be discussing with our patients and their relatives about whether it is in their best interest. The other two are endoscopy and colonoscopy, or CT colon. For this chap, I mean, while he's delirious, no. If he regains to a level of cognition that's normal for him, and he could tolerate endoscopy, then potentially. Colonoscopy, probably not, and even CT colon, because you still need to take the prep for CT colon and colonoscopy, and it's just something that people won't tolerate necessarily if they're frail. So moving on to treatment. So we've said that we need to identify and address the underlying cause, but the important thing, unless there's a decision made, that it wouldn't change any further management. We need to replace the iron, and we can do that in different ways. Oral iron is something that probably most of you have seen commonly, and I thought I would just mention a little bit IV iron because it is something that we generally get asked about a lot, as whether it's appropriate to give. And then the other thing to think about is blood transfusion, but we should only be doing that for people who are severely anemic or hemodynamically unstable. If they can tolerate having iron replacement, then we should be doing that really, rather than blood transfusions. So a little bit about oral iron versus IV iron. So oral iron is generally effective, it's readily available, and it's inexpensive. However, up to 70% of people report gastrointestinal side effects. So that's can be either constipation, nausea, vomiting, diarrhea, just the works of them. In particular, the thing to think about is that this is most older people have these side effects, and it's whether they can tolerate them. So there is a higher incidence of them. So we tend to prescribe at a low dose, and there are lots of randomized controlled trials that have shown that low doses are just as effective in the elderly, and they have significantly lower side effects. And actually part of the stop criteria for older people, so this is like a screening tool that GPs use to look at medications that could be causing side effects essentially in the older population and to consider stopping them. if you're having more than 200 milligrams of iron a day, that's actually part of the stop criteria to reduce that down to either 200 milligrams or to stop it. So the doses, these are the ones that we tend to use: ferrous sulfate, ferrous fumarate, probably the two most common. So when I say 200 milligrams, obviously 210 is allowed. And then IV iron. So we can consider IV iron in particular for people who have the side effects for the oral iron, and we might find that more common in the older population. So we actually have a lower threshold probably to use IV iron in the older population than oral tablets. If they're having ongoing blood loss that exceeds the capacity of that the oral iron will meet them, because it is a higher amount of iron that you're going to be giving in one infusion. If there's a reason why they wouldn't absorb the iron, then there's a reason to give it intravenously. And heart failure, for some reason, they seem to like to use IV iron. And on the next slide, I've got the evidence for that they use in the European Society of Cardiology guidelines, that it seems to be their first choice for iron deficiency anemia and heart failure. So now, probably most of you know when the IV iron, you had to, well, you still have to have a doctor on ward, but you had to have a doctor on the ward. You had to prescribe all the sort of extra medications in case they had an anaphylaxis reaction to it. And now the formulations of IV iron that they produce are much safer, and they have better toxicity profiles than what they used to have. So it's also lowered the threshold of us deciding to use IV iron than oral iron. So these are the adverse reactions that we used to have. So there is a dose calculation, and there is a form on the internet for Sheffield, which takes into their body weight and their current hemoglobin. If it's over 100, probably we shouldn't necessarily be using IV iron, and it's definitely something that we'd need to discuss. And even I would discuss that with someone senior than me, maybe in haematology or in gastroenterology. You might need 2 infusions depending on how much you need, because you can only have 1,000 milligrams at a time, and they're done a week apart. So it would potentially, if we use more IV iron, it would reduce the risk of red cell transfusions and the transfusion-associated risks with that. But there are contraindications to using IV iron. So if you're hypersensitive to iron products in the past, then you wouldn't use it. If it's not an iron deficiency anemia, you wouldn't give them IV iron. If you have a history of iron overload or disturbances in how you metabolize or use iron, you wouldn't give IV iron into the vein. And decompensated liver disease is another reason not to use it. So this is the European Society of Cardiology heart failure guidelines. And you can see here that they recommend intravenous, this is the iron formulation, and it should be used for symptomatic patients with heart failure with reduced ejection fraction, so that's people with left ventricular systolic dysfunction and iron deficiency, and they give you cut-offs of when to use it, and they feel that it's the evidence is good to use it in people with heart failure. So the next case that we're going to think about is a high ferritin. So this chap now, when we've looked at the haematinics, has still got a normal B12 and folate, but now has a high ferritin, extremely high ferritin of 8,000. So the rest of his full blood count, his hemoglobin is the same, 87, which we know about. He's now normocytic because it wouldn't make much sense for him to be microcytic. And then we do his iron studies. It wouldn't be part of the policy, but I just thought I'd show you because I've just shown you that table of the iron profiles. So he's got low of everything. So that means that his iron is somewhere else, essentially, not in his blood. And then when we do some more blood tests, we find that his white cell count's very high, his neutrophils are very high, and his platelets are a bit low. His lymphocytes are normal, though. So he's got signs of infection and potentially quite a severe infection. So when you start seeing this picture, this is where, especially with a ferritin probably over 5,000, you start thinking about your sort of very high inflammatory responses, and then thinking about your cytokine storms. And this isn't something, again, that I would ever expect people to take on, but if you did see a ferritin that high out of hours, I would want to know as the medical registrar, because there's probably something more that we need to do with that patient. So we need to think about high inflammatory response, and the main thing to think about is something called HLH, which I've written down because I can never say it. I only ever call it HLH. Let me just find it. So it's called hemophagocytic lymphohistiocytosis, and essentially it's a cytokine storm. So it's when your body is attacking itself. And the reason why we're doing ferritins in coronavirus, in COVID, is because some people are getting these high cytokine storms associated with it, and they need further management. So 2 reasons to think about high ferritin. One is hemochromatosis. So that's the genetic abnormality, which means that you have very high iron and you get it stored in other parts of your organs, essentially, in particular the liver. You get liver dysfunction, you get liver cirrhosis associated with that. And then the other thing to think about is acute phase protein reactions. So inflammation, so infection, but then other things to think about are cytokine storms. So we've got HLH there, masses, macrophage activation syndrome, and Adult-Stills disease. But it can also be raised in malignancy and liver disease as well, just as that general ongoing inflammatory process. I initially, when I was practicing this talk, sort of felt that actually hemochromatosis is something that you don't really need to worry about in older people. I think probably first diagnosis is true, but actually I've got someone on my ward at the moment who's got hereditary hemochromatosis, who's 92, which is great for him that he's lasted that long with it. He's actually now anemic rather than having a high HB associated with it, but his ferritin is sort of constantly about 1,200, and it has been for years. So hemochromatosis, that's just showing what the iron profile would be. You just have a very high transferrin, so that's your transporter saturation of iron. I say iron is sort of everywhere. The LFT is probably deranged. This is the gene that they look for if you are considering to do it. And then we're looking at liver biopsies. I say this sort of first presentation you wouldn't see necessarily in the older population. And then the other thing is the acute phase reactants. So when you're starting getting over 1,000, that's just when you just need to start just having a little think about what's going on with the patient. Again, sort of 1,000 probably isn't that high anymore, but most people, if they've got an infection, you probably see it in like the 800s. But especially if you're getting into the high thousands up to nearly 10,000, that's when I definitely start being concerned, and I would definitely run that past the registrar who's on call. And in particular, the things to look at are they immunosuppressed? So are they at higher risk of having this type of cytokine storm? Is their temperature, you tend to see it swing, and it goes up and down, like those kind of Perexes of unknown origins, and in particular if it's going up above 38.4. And then are they cytopenic as well? So that's one of their lines. So the is gone. So they have a low HB, low platelets, or even low white cell count. If you're considering that this patient's at high risk of HLH, there is a screen called an H score, which you just get on MD Calc. And now they do ask as part of that whether the patient is COVID positive. But to do that, you have to have the triglycerides clotting, and I can't see the last bit there. And liver function tests as part of that. AST as part of that score, and it gives you a percentage of whether you think the H score is likely or not, essentially. I've only ever seen one person with this condition, but I was very pleased that I made the diagnosis. So treatment-wise, hemochromatosis, they have venesections, and they have like a cut-off with the hematocrit, actually more than the hemoglobin, of what level they need to get below. Before to maintain sort of healthy iron levels. As I said, there is a risk of cirrhosis, and there's a more than 10% chance of developing hepatocellular carcinoma in the future associated with that. And then with the acute phase response, I mean, it's just treating the underlying cause. So if it's just an infection, it will come down as the infection gets better. If it's malignancy, I guess it's malignancy gets treated, that will improve. If it is this sort of cytokine storm, then they actually use IV steroids. I think it's IV methylprednisolone. If we are thinking about that, I don't know in the times of COVID, but prior to COVID, the rheumatologists were really interested in HLH in Sheffield, but obviously rheumatologists don't live everywhere. So in other trusts, it's normally the haematologists that look after HLH and these cytokine storms. So then moving on to B12 and folate. So this is the third case, again, still with the thought of that 87-year-old in the back of your, 86-year-old in the back of your head, with sort of his comorbidities and clinical frailty score. So this time we have a normal ferritin, and his vitamin B12 is low and his folate is very low. So again, he's anemic at 87, but this time his MCV is high because he's macrocytic, so his red cells are large, and that's because of the low B12 and folate. So what happens if your B12 and folate are low? So you get hematological problems. So like you can see here, you get changes in your bone marrow, you get the large blood cells, you get pancytopenia, so your platelets and your white cells can drop. And actually it's one of the first things that if you send a nice referral to the hematologists of someone who's got either low white cells or low platelets, the first thing they send back is, have you done haematinics? So it's always worth doing beforehand. However, anemia and macrocytosis are actually more late features, so you might find that they have low B12 and folate on the haematinics without the anemia and macrocytosis, and it's better to pick up earlier. You get potential abnormal taste and inflammation of the tongue. And then in particular, the things that we get more worried about are the neurological effects, in particular of low B12, which can cause irreversible central nervous system complications, and they can be present even without the patient being anemic, as the anemia and macrocytosis can be late features of B12 and folate deficiency. Peripheral neuropathy is probably one of the main things that we think about, again, in the older population, and it is a risk for them because of falling. If you don't know where your feet are, it's going to be hard to fall. You are going to fall. And then also cellulitis, because if they stand on something that causes infection, then that's obviously not good for the older, frail adult. And then the psychiatric symptoms, so delirium, why we do it in delirium screen, and then dementia. So B12 can be low in up to 15% of older people. It's found in these food products, which you can see it's not in plants. And body stores apparently are sufficient for 4 years. I did try and find a picture, I'll just put these last bits up, of sort of the B12 absorption, but there was nothing that didn't have like 20 steps in it, so I thought it was worth leaving off. But essentially it is combines with intrinsic factor in the stomach, which is the key factor that you need to remember, and then it's absorbed in the terminal ileum. And then same with folate, often seen in hospitalised patients. It's found in these food products. And again, its body stores can last for about 4 months, and it's absorbed in the duodenum, so again, in the small intestine. And then we know that a maternal folate deficiency can cause fetal neurodefects, which is why people take folate supplements in pregnancy. So causes of low B12 and folate. I mean, the important one in B12 is pernicious anemia, which is an autoimmune atrophic gastritis, and that's the lack of that intrinsic factor in the stomach, which then it's not absorbed properly. Again, I think it is present in the older population. I have to say, I don't know the last time I did an intrinsic factor on someone who was 86. I probably just replaced the B12, but definitely maybe the slightly younger people that you notice B12 deficiency, it's probably worth doing. So these are the other causes of low B12, and the main one is poor nutrition, so poor oral intake of B12 and folate, and again, it's something that we see often in the older population. But then I guess you can see here that an increased demand, where it has increased cell turnover, you know, a lot of older people will have malignancies or inflammatory disease, which would potentially cause these low B12 and folate. Again, malabsorption is always an important one to rule out. Drugs, we know with methotrexate that we replace with folic acid on the days that you don't take methotrexate to counteract that. And then altered metabolism, I mean, most of the time, I mean, again, getting up to our older adults, I don't think many of them have autoimmune diseases of thyroid, parathyroid, and adrenals, but it's something to keep in the back of their mind. So further investigations. So again, so for pernicious anemia, that's when you're thinking about your parietal cell antibodies and your intrinsic factor antibodies. As I said, I don't know the last time I ever did that in an older person, which might be bad on my part. But probably I would end up just, if someone had a low B12 and they were older, I'd probably end up just treating it. I guess the difference is that if it definitely is pernicious anemia, you'd need to be on it consistently. And if it was nutritional, then you might think about giving oral supplements instead. And pernicious anemia definitely to give intramuscular. So I guess it would change it there, but I don't know when we last did it. I think a lot of people just end up getting the injections. I would potentially do a celiac screen again. Whether I don't think I would do an endoscopy or a duodenal biopsy, because I don't think that's appropriate in an 86-year-old gentleman to find out why he's got a low B12 deficiency. And the same with folate. I think the important thing with folate that they've noted in the books is that you should really have a normal B12 to diagnose a low folate, and actually as you replace the B12, the folate might come up. So it's just something to keep in mind. So treatment of B12, so consider the underlying cause. So most of the time you'll see that people will get 1 milligram of hydroxycobalamin 3 times a week for 2 weeks, and then they have it every 3 months. If they do have central nervous system signs, then you can actually give 1 milligram of hydroxycobalamin every other day until the signs either resolve or they stop getting better. If it's malabsorption, then you'll need to give injections because they won't absorb the tablets. If it's purely just nutritional deficiency, so dietary, you can actually give just oral cyanocobalamin, which you can see the dosage there, but you just have to give it between meals rather than first thing in the morning. And apparently peripheral neuropathy may improve after 3 to 6 months, but apparently even if you've already got cord signs, then it's not very good. So again, with folate, so you're thinking about the underlying cause. If you do have anemia, then you would be giving the high dose of folic acid, so 5 milligrams once a day. If it's just dietary deficiency, but you don't have anemia, low platelets or low white cell count, so no cytopenia, then you can give the lower dose of 400 micrograms once a day because it's just a nutritional top-up, essentially. You would give folate only for 4 months normally. And then the important thing to remember is actually if they have low folate and low B12, you need to replace the B12 first before replacing the folate because of the risk of causing subacute degeneration of the cord, which is like leg weakness with, I'm trying to think, I think it's increased tone but downgoing reflexes. So your plantar be downgoing and you'd have absent knee reflexes, and pretty soon it's that way around. So that would impair your mobility. So say for this chap, he had low B12 and low folate, I would probably give the 2 weeks of loading of the B12, so every 3 times a week for 2 weeks. And then you could even recheck the folate again to see if the folate's come back up, and if it hasn't, then you could probably start giving the folic acid. So the other thing just to consider is about blood transfusion and B12 and folate, and it's important just to remember this is only in like the megaloblastic anemia. So it can cause impairment of the cardiac function. So they are wary of you giving blood transfusions if it's the anemia solely for this reason. So if because there is a risk of overloading the patient, and if you think in our older adults as well who already have a bit of ischemic heart disease, then they're probably at slightly higher risk. So what they suggest in the book is severe symptomatic anemia. You can treat with bed rest, which I've written because as a geriatrician, that's just like the worst thing in the world because people get deconditioned so quickly. And then high concentration oxygen, which it just doesn't seem ideal. While you wait for a response by giving the B12 or folate, B12 if both of them are low. And they say that the HB concentration starts to rise in 3 to 4 days. But if you think about our frail older adults, in 3 to 4 days, deconditioning has happened. So I don't know how much I agree with that, and I don't really know the answer, but it's probably just if you come across it, then discuss it. I think a lot of the time anemias are multifactorial. They're not for one pure reason. And I've never really seen anyone who's got like an HB of 50 purely because they're B12 deficient, but I'm sure someone has. And they're saying if the red cell transfusion is essential, then you just need to give it slowly, so over 4 hours, and potentially give some diuretics with it and monitor closely. So the other thing just to think about is how often do you see this when you chase your haematinics? So the folate's over 20, the B12 is high, and you've got a normal HB. And it's just something that I think we're really bad at doing, is when we do start folic acid, is actually getting the GP to have a look at it in 4 months' time to decide whether they still need to continue on folic acid, because if it is just a nutritional issue, then they probably don't. And it's just another tablet for an older person to have that they don't need. A lot of us end up stopping folic acid in hospital because they just don't need it anymore. And then the other consideration is why they're on B12. If it is, again, just for nutritional deficiencies, then you might be able to stop it. But for other causes, potentially not. So things just to take home. So with ferritin, if it's less than 15, think iron deficiency. It's over 15, but they look like they've got iron deficiency, then do some iron studies to help you diagnose it. Maybe Google and screenshot an iron studies table, so when you're out and about. If the ferritin, I put over 1,000, because technically I think that is what they suggest, but over 1,000, you probably will see people over 1,000 and they don't have a cytokine storm. But if it is over 1,000 and you've got someone with really high temperatures, with pancytopenia, who's immunosuppressed, then just pick up the phone and speak to one of the regs, because it's just starting to think about what is going on. And especially if you see them in like the high thousand, 8,000, 10,000, then definitely pick up the phone. And then just some of the indications for IV iron rather than using oral iron. And remember to start low with your oral iron dosing. And then with vitamin B12 and folate, just think what the cause is. Replace the B12 before the folate, and just trying to avoid red blood cell transfusions if that's the reason why they're anemic. So I guess if there's any questions, let me just try and get back to, how's everyone? Let me stop sharing. Hi. I don't have the chat for, oh, there is a chat. Is that me? Yeah. Cool, okay. So that's it. If anyone's got any questions about it, then please ask. I know it's quite a lot of information in one go, but I hope it was useful in some respects. Is Nazia talking?
Sorry, I keep forgetting. I saw a patient on Tuesday night and I had to chase the haematinics, but they were normal. But the iron profile, the iron was 5.8 and the percent IBC saturation were 14, and the total iron binding capacity was 41.8. But the MCV was normal and the HB was normal.
Ooh.
So I thought that because he was recurrent aspiration pneumonia, I thought it was illness related.
Probably. So was the serum iron normal? Sorry.
Serum iron. Is that 5.8?
So that was low.
Low.
Yeah. So it does sound like it probably does sound like it was like you say, associated with this illness and with inflammation. You would normally expect was the ferritin normal?
Yeah, all the haematinics were normal.
Fine. I guess
ferritin was 248.
I guess the question would be, is that slightly higher than normal for him, and whether there has been a raise in the ferritin, which would be that acute response, and then you would expect those changes in the iron studies. My question would be why did they do iron studies in the first place?
He was medically fit to go home. They were aspiration pneumonia, COVID negative, and just had ischemic heart disease. They did them in December, but they were hemolyzed. I think it was just routine.
And if the ferritin's normal and they weren't suspecting iron deficiency anemia, why are they doing iron studies?
So that's what they put on.
Which I know is out of hours, but probably that's what I'd write back in the notes to the team. Is why, because like there's no they're doing tests for the sake of doing tests, But yeah, I think you're right. I think it probably is like what you're saying, it probably is to do with that acute phase reaction, and to do with his illnesses, and whether maybe the ferritin was maybe a bit lower before and it's gone up associated with that. But it's a bit of a guess.
Cool, thank you. Anybody else have any questions?
I've got loads. I'm just trying to process it all. You know, if you had somebody with like symptoms of, I guess taste, loss of taste is one that we're looking at COVID now, but so like as part of like a comprehensive investigation, would you look at ordering iron studies and haematinics anyway? I mean, like if you've got somebody with swinging pyrexias and you've not got an origin for that, is that something that you would do? I would do
the ferritin, definitely.
Yeah.
So if I've got someone with pyrexias and I don't know why, I would do the ferritin, because if that comes back as very high, then I would start doing those other tests to look at like a cytokine storm or not, because we don't know what the inflammation. So it's the firework and what it's proof of inflammation, but it's not telling you why. But it is quite a good sensitive marker. And if it was up in the, in that 8,000, 10,000 region, then you've got a reason to start thinking and doing other things to maybe do that, like H-score for HLH, maybe. When you go through the H-score, it's quite specific, and actually when I always get a bit excited, and when I've done it before, it's not always that high, and I get a bit disappointed. There's like a percentage chance, but once it was very high, so I was very pleased with myself.
And so then you'd only go on to order iron studies if your ferritin is high?
Low.
Is that low? Right, okay.
Well, no, sorry, that's a lie. So if it's over 15, but you have a picture of iron deficiency anemia on your full blood count, then I would start doing iron studies.
Right.
I guess the other reason to do it is if the ferritin is high and you're worried about hereditary hemochromatosis, there'd be a reason to do iron studies, because it would again give you proof of the fact that particularly your transferrin saturation is over 80%, and that would give you an indication that it's hereditary hemochromatosis.
Thank you.
Yeah. Anyone else got any questions at all? Fine, you can always email me if you think of something at some point, and I'll give you the answer back. Sorry, Navi.
Will you be able to share the presentation with us, or is that all right?
It's and then you can email it out. Is that the best thing to do?
Yeah.
Cool.
Best. Thank you very much. I'll see you next week.
Thanks.
Thank you, everybody.
Thank you.
Thank you.
Thank you.